Even in the midst of the COVID-19 pandemic, hospitals are working toward value to ensure better care for patients and communities. Welcome to Advancing Health, a podcast from the American Hospital Association. I'm Tom Hetterly, Senior Writer with AHA. Priya Bathija, Vice President of the Value Initiative at the AHA, and Dr. Bob Pendleton, Chief Medical Quality Officer with University of Utah Healthcare, come together again to discuss how University of Utah Healthcare is looking at value as a result of COVID-19. Priya?
Thank you, Tom, and thank you, Dr. Pendleton, for joining us today to discuss how the conversation around value has changed during the COVID-19 pandemic. Have you noticed any changes in how physicians, hospital leaders, or even patients are viewing value during this pandemic, and how is that different than what you were seeing before the pandemic?
Yeah, well, thanks, Priya and Tom, for the opportunity to share some of our experiences. This has really been truly unprecedented time, certainly in my 25-year career. And, at University of Utah Health and in our community broadly here in Salt Lake City, I think we went into this pandemic with a pretty strong view of the importance of driving value in healthcare delivery. And I think the COVID pandemic has amplified that even more. And as I was reflecting on things, if I were really honest with what I see now versus, say, 6 months ago, I think we viewed value as a nice to have, not necessarily a must have. And through the COVID pandemic, it has become clear that it is a must have. And probably the best example of that is in the whole space of appropriateness of care. It's one thing to drive value through efficiency, et cetera, but it's even better if you don't do care that's not necessarily needed in order to have a patient live their very best lives. And when you are focusing on trying to keep your patients and community safe and everyone has stay-at-home orders, and your providers are worried about, healthcare acquired COVID, you really sharpen your sense on what care is appropriate and necessary to help patients and what care may not be necessarily appropriate or necessary. And I think that accelerating the conversation around appropriateness has definitely been part of that. And one example of that is here, we did very little telehealth. It was easier to just have patients come into the clinic and see them in person. But when you're sort of thinking about what's appropriate and how do you deliver the right care in the most cost-effective, efficient, patient-centered setting, well, all of a sudden, telephone, televideo visits, et cetera, start to take on a whole new meaning. And we went from a handful of televisits a month to that being over a third of all of our ambulatory encounters. So again, appropriateness would be how I've seen the biggest change.
Yeah, thanks for sharing that. And as you made that transition from only having a handful of telemedicine encounters to having about a third of your ambulatory visits done through telemedicine, what type of results have you seen? Have patients been happier with the care that they're receiving? Have you seen any change in perspective from clinicians as they deliver care in that new way?
Yeah, I think it's a learning curve on both sides. I think patients have very much embraced the patient-centeredness of and convenience of using technology in a more meaningful way as a part of their healthcare delivery platform. The downside is any new way that you deliver care, there's some kinks and glitches that have to be worked out in terms of how the visit flows. But I think patients by and large have been very, very embracing. Our providers is interesting because I think initially there was a lot of skepticism, and then I think as providers have learned kind of back to appropriateness of what types of patient encounters can you actually deliver high-value care through a technology platform versus what ones do you need to lay eyes and hands on a patient and have them in front of you. And I think that as providers have worked through that learning curve, there's been a marked adoption of that as well. So still a work in progress, but I think both for providers and patients, I think it will definitely take a much stronger foothold as a very important part of care delivery.
Right. And building on that, Bob, we've talked in past conversations on how important it is to have collaboration between hospital leaderships, clinician leadership, and how that's really important to the value conversation and how we provide care to patients. Have you seen that change at all during COVID? Has that conversation increased as you take on new care delivery pathways?
Yeah, I think, again, sort of accelerated and amplified are the two words that come to mind. On one side, I mentioned that there's this learning in how you use technology to drive value-based care delivery between patients and providers, and that collaboration of listening to each other and learning through that together has been really accelerated. And we've done patient surveys around televisits. We've created a patient and family design studio to help co-create and co-improve that technology-based delivery. So collaboration's been really amplified. But even more than the patient and provider collaboration, the thing that has really struck me is the community level collaboration that COVID has really fostered, forced us to embrace, et cetera, which gets at how hospitals, doctors, patients, community partners all need to work together for the betterment of health in the community as a whole. And just a couple specific examples. So in our market, University of Utah Healthcare, our largest competitor, if you will, is Intermountain Healthcare, another world-class, well-known healthcare organization. And then we have two for-profit systems, HCA and Steward. And normally we all kind of compete in our own silos, and there's not a lot of collaboration. But when you look at the lens of how do we keep our community safe, all of a sudden collaborations flow. So a couple of my favorites that I wanted to share. One is our community partners and some of our religious organizations, Intermountain Healthcare and University of Utah Health, partnered together to take advantage of the enormous volunteer spirit that resides in Utah and created a project called Project Protect, where we sourced medical grade material and engaged thousands of community sewers who just this last weekend completed and delivered 5 million medical grade masks to keep our healthcare workers safe. You hear all these places that run out of personal protective equipment. That's not the problem in Utah. And again, a good example of this collaboration. Another is, Utah, like most places that are described in the country, is COVID really highlights disparities in care. And areas that are more socioeconomically disadvantaged, there might be a higher density of multi-generational families living in the same setting, that we know that COVID becomes harder to control and can lead to more negative outcomes. And so we, similarly, in a part of our community, we have rallied together to take mobile testing vans to areas that are the most vulnerable, to identify people earlier. We've partnered with state, city, and local community leaders and agencies to then provide the support necessary to keep those communities safe once we identify an increase in COVID cases. So those have been things that have been very inspiring to me, to really look at moving away from viewing these different entities as competitors and really rallying together to meet our community's needs.
Yeah, that's really great to hear and to see that spirit of collaboration. Bob, what do you anticipate will change in terms of value and affordability after we get through the COVID-19 pandemic?
Yeah, I think that, in my opinion, we've been talking about value for a long time, right? And 10 years ago, I always used to say, "Oh my gosh, healthcare is creating such a high percentage of our GDP. We have, inequities and accessibility to care." 10 years ago, I said we will have achieved value by 2020. Well, it's 2020, and we've made some meaningful progress, but not nearly enough progress. In my mind, COVID is going to create a very sharp inflection point, and as healthcare systems that financially are being devastated through a loss of revenue through this pandemic, will wind up needing to not try to play this middle ground. I think some will be drawn to amplifying a for-profit mindset as they try to restore their own financial viability and meet the needs of their communities. If that's the path a majority of healthcare providers take across our system, then we're going to take a step backward from value and affordability. What my hope is that we will come out of this having learned lessons that we've talked about around patient-centeredness, around appropriateness, around the use of technology to drive value, the need for preventive measures and partnerships with our community partners. And if we do that, then COVID may be the catalyst we've been looking for to really accelerate our push towards value and affordability. So again, I think it's an inflection point. My hope is that we follow the latter path, and I think we really are going to have to guard against a normal tendency to want to do more for profit's sake, even if it's not the right thing to do. And again, I believe in the people who work in the healthcare industry, and so I'm cautiously optimistic that we will use this as a catalyst for transformation.
Well, Dr. Pendleton, thank you so much for being with us today, and I share your hope for the future in terms of how we move forward looking at value as a path to achieving patient-centeredness in the future. So thank you again for joining us, and Tom, back to you.
To learn more about University of Utah Healthcare's journey on value, listen to Priya Bathija and Dr. Pendleton's first podcast, titled Building a Culture of Value.